So to that point, James, how would you approach this patient for treatment? Let's say you've got this data, the patient is now sitting in front of you in the inpatient. What would you discuss and offer?
Yeah, so I think that we have this patient, 44-year-old woman with confirmed FLT3 mutated disease. She does have some other concerning mutational abnormalities for me. I think most notably the P53 mutation. But considering all of that, this is a patient who's not had therapy before, and this is a patient who we would certainly consider for induction with 7+3 plus midostaurin based on the results of the RATIFY trial.
Yeah, and with these people, you would do the midostaurin day 8 to 21, is that, or would you do continuous? I know people have debated this.
Yeah, so for us, we would do the midostaurin according to the protocols on day 8 through 21. I think the rationale behind that was twofold. I think from a molecular standpoint, there was some concept that potentially inhibiting FLT3 up front might reduce the cytotoxic effects of the chemotherapy. But additionally, when we gave the drugs in combination with chemotherapy continuously, there was some concern regarding toxicity, which, as we'll discuss, was much more tolerable, I think, when we gave it for a 2-week period following the induction chemotherapy. And we would ideally start it on day 8. I think that when you talk to folks in the community, we already talked about the potential lag behind with molecular results, and then navigating potentially that patient's insurance provider. It's unfortunately not unusual that we might be starting midostaurin after day 8, and I think that's not ideal, but given the data we have, I think it makes sense to add it when it's available. So, even if that starts on day 11, that would be our standard protocol, and I think probably the best approach in the real-world setting.
And I think that's important because we get a lot of calls, and I'm sure you all do, that I got the result on day 10 or 11, and should I just not do the midostaurin because I'm not fitting the protocol? And I think, there's no data, this is for this, but we would also just do it from day 10 for 2 weeks, because I think adding the TKI is probably more important than just doing it on day 8, which is optimal. So, Dr. Azeri, what do you think?
I think it highlights the point of working with good pathologists to get the data back quickly, because there certainly seems to be more and more evidence that earlier addition of FLT3 inhibition is important. And so we want to push to get that data as soon as possible.
Yeah. So, Dr. Azeri, let's have a little bit of a curveball, but something that we get asked at all these symposia. What about if this patient had MRC changes, and let's say this is a younger patient, let's say it's a little bit older, 66-year-old, and has a FLT3, which is, we thought it would be very uncommon, but about 20% of the people in the VYXEOS study had it. What would you do for this patient? Would you say, I go for FLT3, the TKI is more important? Would you consider VYXEOS? Would you consider Aza-Ven? Just, there's no right answer, but what do you think?
So the short answer is yes. And I could see doing any of the 3 scenarios you laid out depending on the patient conversation, right? That's why we're, I think, privileged in many of our clinics in academia to still have enough time to sit and have this shared decision-making conversation with the patient to try to best understand their goals of care. If we're initially looking at this as a curative event, then right or wrong, I still feel that aggressive therapy today would still be what I'm leaning to. And in terms of aggressive therapy in the scenario you laid out, then I would choose the CPX-351, which we'll get into some of that data, I think, was one of the other cases, and lead to transplant. However, in this particular case, we see the P53 abnormality as well, and that really concerns me. I'm not sure we're benefiting these patients with aggressive chemotherapy very much, and so I wouldn't feel badly if in consultation with a patient or another referring physician, they went a different tact of, say, a Ven hypomethylator combination or something like that. I don't think would be unreasonable in a number of these patients. So I think any of those would be on the table in my view. I'd be curious what my colleagues think.
Anybody else feel differently about this, or?
I mean, I think I agree. I think some of it's going to be around, a lot of it for me would revolve around age and what is the AML MRC. So, was it just multilineage dysplasia, in which case I don't find that often as convincing of an argument to pursue VYXEOS. I mean, I think the data there is a little more conflicting. And I think the P53 mutation is really the most challenging. For me, in a 44-year-old, I completely agree that I'm not often excited about the efficacy endpoints in these p53 mutated patients, but I think for us, we're trying to use VIN and hypomethylators still conservatively, acknowledging that the N in those clinical trials where we're drawing this presumed kind of better response, which was very impressive, is relatively small. But I think if I'm on the fence, certainly an older patient, maybe a patient who has some other borderline comorbidities, then I'm certainly much more inclined, I think, to think of that patient as a better candidate for less intensive
So
therapy.
I think you both brought up some couple of very interesting points for the audiences. One is that, this age, or let's say fit for chemo, is no longer purely being based on age. It's really more on biology, because both of you said TP53, and I totally agree with that. A 40-year-old TP53 is not really much better off than a 60-year-old or 65-year-old. And I think we're starting to see this, where people are saying even for younger ones, is there benefit to giving them chemo? The second thing you said, which I think something in Anderson we're looking at too, is all MRC the same? And I think the feeling is it's not, that some of these softer MRCs may not be the same negative prognostic as the ones who are true MDS, secondary AML, but there's not enough data for that, so I think we have to look more into that. And the third, of course, is, could you combine these agents, which is something that people are going to look at. Can you add Vyxeos? And there are trials ongoing for that, and that could be a good patient for those. So there's no right answer. I mean, I think we're in a privilege where the right answer 5 years ago was always 3 + 7, and today we can have 3 right answers, so that's good.